Thank you very much. Good morning. It is my great pleasure to share our experience with you, and I express special thanks to Professor Luis Lopez-Ibar for this opportunity. In this talk, I would like to mention about our experience on the carbon science Dura ABF. Based on our data, it's most common lesion in Korea, 56%, compared to the high incidence of transverse sinus lesion in the Western countries. However, hemorrhage or edema is much less in the cavernous sinus, as you know, compared to the high in the transverse sigmoid, ethmoid, convexity area, petrous, and superior sinus. When we divide into three phases, as we defined when there is a occlusion of the antegrade venous drainage, we call this restrictive phase. That's the most common lesion phase. As you see here, the proliferative phase 40, and the less common of the late restrictive phase. It shows stasis of vein of the contrast. When we briefly look at the anatomy, two dural margin contact with the subarachnoid membrane with fine numerous vascular anastomosis, and even in the normal anatomy, there can be a microscopic fistula in between the dura. It's interesting to see when we see the integrity of vein after removal of the dura in superior sinus. In contrast, in pituitary area, we cannot see any dural margin between the pituitary fossa bone and the medial part of the cavernous sinus. So the cavernous sinus is a totally extradural space. Another thing we need to consider is that the enlargement of a temporal lobe during the development of brain. So superficial middle cerebral vein approach to the cavernous sinus. So finally, cavernous sinus capture the vein in the adult pattern. So there seems to be such a variation depending on the presence of cavernous sinus capture. So this paracable or lateral cavernous type pattern of venous drainage can happen. So this angiogram shows the separate venous drainage of the superficial middle cerebral vein into the cranial fossa, separate from the cavernous sinus area. So in addition to the medial and the lateral compartment of cavernous sinus, in the lateral wall of the sinus dura wall, there is a lateral cavernous sinus, as you see here. So this kind of variation make the understanding of this lesion a little difficult. So that's why there is a various venous drainage pattern according to the phase of the disease progression and also absence or presence of cavernous sinus capture. According to Lajanian's classification, cavernous sinus lesion belongs to the ventral type, as you see here in this color area, compared to the ethmoidal AVF as a lateral group, and the transverse sinus dura AVF is a dorsal group. This is a brief summary of the cavernous sinus dura AVF extradural female, more common in Asia. It's known to be a benign disease, but some most complex venous drainage pattern, so there seems to be diverse complication. Proliferative type defined as there are numerous feeders and the bulging of the sinus wall and the well-preservation of the antegrade flow. When this proliferative phase localized to the posterior part in the left side here, then the antegrade flow obliterates. It's called the restrictive phase. Then the vein retrograde flow appears. And then later on, there is a restriction of venous drainage pattern and some stasis on the late venous phase. That means late restrictive phase, and finally lead to spontaneous healing. This is 1A of disease progression in contrast to the end stage of the disease. This is the other part of end stage shows ICA-gram shows dilated cavernous sinus and the stasis of vein. That means late restrictive phase, and ECG-gram shows cortical venous regurgitation, which stays late venous phase. There is an edema, so-called venous infarction in the temporal lobe and the cerebellar area. It's the other side of terminal stage of cavernous sinus dura AVF. So, according to the disease progression, which can lead to a spontaneous healing or the diverse clinical presenting pattern, as you see in the other both sides, according to the cavernous sinus capture. That's why cavernous sinus dura AVF can show a diverse clinical pattern and sometimes complications. Interestingly, females are more common in cavernous sinus lesion, and the overall diabetes is more common in our study compared to the normal population, probably due to hormonal status or the ethnic difference or the angiogenetic factors, etc. We usually try to transvenous access, as you see here. This procedure most effective in the restrictive phase because antegrade venous occlusion is there. It's a little easy to find fistula pouch when we approach it through the occluded vein or the opposite side into the fistula point. So we occlude the fistula point and then we can get the complete obliteration. Sometimes it's necessary to find the fistula point, as in the aneurysm embolization, the shaping of the mitral catheter, to find out the fistula point. Otherwise, it's sometimes very difficult to find fistula, to get into the fistula point. This is transfacial venous approach. In the beginning, we use this technique sometimes when it's difficult to get into the fistula point. But since then, in most cases, we could reach the fistula point through the occluded IPS. In proliferative phase, it's very difficult to find the fistula pouch area. That's the big problem in this phase when we treat this patient. There are numerous feeders and preserved antegrade flow. Even the 3D DynaCT couldn't show exactly where the fistula point is. The embolization was most commonly done in 74% in the overalls, and the operation and gamma knife sometimes used. In the overall number of embolization was one time 80% and some twice or more than 4 in some rare cases. The mode of embolization was the transvenous approach was most common, but in cavernous sinus lesion, transvenous approach was the more, reached to 63%, and the transarterial only possible, and the combined approach in 20%. Overall, there are diverse complications related with the procedure. For the cavernous sinus lesion, we may think some separate complication. Among them, the rerouting seems to be rare, but most serious complication. In this proliferative phase lesion, we embolized with many coils, but we anyhow underestimate this small venous filling in this area. Is not definite on APBO, and the ECA-gram also shows preserved antegrade flow. And then 2 days later, patient developed brainstem edema with hemorrhage, with the working difficulty. That no edema on DWI shows this is a venous nature of the lesion. So we did another angio. Now it's definite, the rerouting of the vein around the brainstem into the deep venous system. So it was not easy, but we entered the cavernous sinus and put another coils, and then could obliterate residual lesion. And then a patient recovered almost completely later on. This is a before and after. We can see a small venous structure in front of the brainstem right side. When we look at the cadeva, I found out that there is some structure there, but this is a very cleanly managed cadeva. We cannot see any structure there. But in description, there is a bridging vein between the posterior wall of the cavernous sinus and the perimesencephalic venous structures. This is so-called bridging vein. Bridging vein is transdural vein, numerous in the dural area. That's very important in the pathogenesis of the cranial as well as spinal dural AVF. Sometimes it's very complex and difficult to analyze cavernous sinus dural AVF lesions. Even the 3D analysis. This is a lateral cavernous sinus lesion and the draining medially into the IPS. The venous face shows a septate to the cavernous sinus venous drainage. We focused on this fistula area, put some coils there, and then even after removal of this part, there is some more draining vein into the antegrade area. So in order to prevent rerouting, we usually preserve antegrade flow in order to induce spontaneous healing, and then if there is any residual or aggravation of the lesion, we can re-enter that. And anyhow, 9 months follow-up show the disappearance of the residual lesion. So the one way to prevent rerouting is to preserve antegrade venous drainage. There's another rerouting case in the literature that showed the brain stem edema is managed by covered stent in the ICA for the residual fistula, and then some particles in the ECA, which can lead to make a patient recover. Cerebral edema, as you see here, there's some hemosider, and here is cerebral edema, and after embolization, it disappeared. It's one of the progressed lesion in the DAVF, and it's a precondition of a hemorrhage. So even in cavernous sinus lesion, we see this edema develop into the massive hemorrhage within 2 weeks. Probably the small PL vessel engorgement was result in massive bleeding. So in the literature, when embolic particles pass into the venous side, reach into the PL or cortical veins, which can cause massive hemorrhage, as you see here. Once there is a bleeding, it can rebleed like this. It's a matter of weeks. And then if it's properly managed, it can almost reverse to the normal state. Another complication is venous thrombosis. It's a complication or one way of healing process. So this engorgement of ophthalmic vein and the rather dilated SOV and the sluggish flow, 2 days later, yes, there is more stages there. And when the patient came to us, the patient became a complete ophthalmoplegic and the marked swelling of the eyeball. And then we did the angio. There was non-filling of the superior ophthalmic vein. The ophthalmic artery comes from the external carotid artery. So we thought this is a typical presentation of superior ophthalmic vein. And then we put low molecular heparin steroid, and then management of intraocular pressure, and then patients slowly get into the return to the normal status, as we see, without any endovascular management. Nerve injury is relatively common, but usually reversible. And in this patient, we put the coils, but 6 nerve palsy developed, but returned to normal, recovered 4 months later. In this patient with marked eyelid swelling and complete ophthalmoplegia, there's a restrictive phase of lesion, and we retrograde enter into the fistula point and protect SOV, and then obliterate the fistula completely. This is the initial, and the patient improved, and finally, the almost completely improved, but 6 nerve palsy still remains. So it's probably from the initial insult, or maybe the tight compaction of the coils. So the now we don't induce tight compaction because of this nerve potential of nerve injury. Recently, I personally experienced a very strange and serious situation like this, and this is a proliferative phase. We usually touch minimally in this proliferative phase, but we enter the venous route to reach this flow, comes from this feeder into this area. So just I put one coil, it's a hydro coil, to induce the thrombosis. There was a little resistance, but not that tight. And this portion was removed, and I introduced particles intraarterially. And then the patient recovered, but the patient had a decreased vision. It was tolerable, but anyway, the vision decreased. That means I thought that this is a possibility of the coil went into the optic canal and compressed the optic nerve. Otherwise, it's very difficult to explain. So transvenous tight packing, when there is a resistance, it's better not to induce a tight packing, especially in the proliferative phase. So in conclusion, carbon-derived FAP is in extradural locations, in the more common in female and the most common in Korea. Although it's known as benign disease, because of the complex venous drainage pattern, there seems to be diverse complications, and especially even edema related with PR venous reflux as a precondition to hemorrhage. Thank you for your attention.
Any questions?
Everybody's okay. Professor Chul.
Yes.
I treated every dural fistula of cavernous sinus in this hospital. Every treated by venous approach. Venous approach.
Venous approach.
Yes. Yeah. And combine the coils with onyx. Because I think it's better to close immediate, complete, in acute, in peri-procedure, you totally close the fistula. But if you only put the coils in the cavernous sinus, you are sometimes the vein is open, still open,
yes,
small
yes.
vein, and this is your problem of the rerouting and edema or ischemia in brainstem or in posterior fossa. And I think the most important, when you treated the dural AVM in cavernous sinus, when I started 20 or 25 years before, I started in Bicêtre. Every time is only with arterial. And then in San Francisco, Hiroshima, I started with the venous approach. And about 10 years, after 10 years, only treated vein with coils and onyx. This is very, very, very important.
I agree your idea that in my personal experience and my opinion, we usually try to get into the fistula point and protect the cerebral vein and superior ophthalmic vein by coils. I think it's a little clear. Otherwise, the onyx usually maybe it can spread everywhere and ablate everything, but it's a little difficult to induce the purposefully and intentionally goes to some point. I think it's a little difficult. No?
No. It's very easy. Very, very easy. Because you are the control flow. You put about 1 or 2 or 3 coils. I prefer to use the fiber coils. You know, the fiber coils is the coils of about the Target, and now EV3 or Medtronic have a fiber coils. Henkens is here maybe, no? Henkens, coils of Dendron. And it's very, and you are the same catheter, with the same catheter.
Yeah.
You use the Barrow catheter compatible with onyx. You continue injection of onyx, and when you are free going one part of your light, you wait, do the same with AVA, and going in other side.
So any cranial lobe damage or
less because
less means
because you are less mass effect. Less. With the coiling, sometimes you are the mass effect of the nerve and pain of the trigeminal compression, but with the onyx, no. Another comment is when you study the fistula and the sinus petrus is closed, don't problem, because it's possible to open this sinus every time. I open the sinus petrosus inferior, and you with the guide wire, and you continue to open. And the ophthalmic approach is bifacial, tubular facial, or direct punction in the vein, in ophthalmic superior vein. And have one case is described is published in literature with the direct punction of the foramen valve and going to the way of the trigeminal approach. You turn and you close the fistula. I think that the dural fistula of cavernous sinus is before the period of the onyx and venous approach is very complicated to treat it, but now for us it's very easy.
Thank you very much for your comment.
Doctor, so I know treatment of dural fistulas is very, very difficult pathology. My question, how do you protect its dural carotid cavernosus fistula from migration of embolic material in internal carotid artery? But this distance is very short, it's possible 2-3 millimeter. You have complication with migration of embolic material in internal carotid artery.
Migration from where to where?
From external, so after transvenous approach of superior ophthalmic vein, you push embolic material in this nidus of fistula.
Through the ischiae.
It is distance from fistula and internal carotid artery. It's very, very small, very short. It may be millimeter, 2, 3, 4 millimeter.
So you mean the ECA particle can enter into the ICA?
Yes.
I don't know. I'm not sure that because can be dually supplied. Sometimes has the only supply from the ICA, but usually they can have a dual supply. So if we touch ECA branches, unless there's a forceful injection through the wedge position, regurgitation into the ICA usually not happen. But be careful not to regurgitate into the ICA through the dural anastomosis.
Yes, it's possible to see this when every time you are the hypertrophia of lateral trunk of the cavernous sinus, when you are the fistula, or you are the anastomosis with the ophthalmic, with the redondo mayor, or with the posterior part of the siphon and the clivus. And when you use the onyx in the vein, it's possible, and you are migration in this part, and you are secondary migration in the siphon. The solution is every time I put one balloon in the siphon, but this balloon is not to close it's only to see where is the limit of your migration. It's not to close, but you close the siphon, you are open another anastomosis. It's only to see when stop the migration of onyx.
Thank you very much.